Ladies and gentlemen, you may please take your seats, and I invite the following dignitaries to take their seats at the head table. President of the College of General Practitioners of Sri Lanka, Dr. D.K.D. Matthew, the orator, Dr. Carmel Elizabeth Indrani Fernandopulle, Senior General Practitioner, Secretary of CGPSL, Dr. Dumindu Vijayawardena. The highlight of today's session is the awarding of the prestigious Dr. B.D.J. De Silva Memorial Medal and the Oration 2022. The orator this year, Dr. Carmel Elizabeth Indrani Fernandopulle, a Senior General Practitioner, is the orator. To do the honors, may I kindly invite Dr. D.K.D. Matthew, President of the College of General Practitioners of Sri Lanka, to introduce her. Thank you.
Good morning to all. Today's Dr. B.D. J. De Silva oration will be delivered by our past president, Dr. Carmel Fernandopulle. Dr. Elizabeth Indrani Fernandopulle had a primary and secondary education at Good Shepherd Convent, Colombo. There she served as a prefect, deputy head girl. She entered Faculty of Medicine, University of Colombo in 1973 and graduated in 1978. She completed the internship at Lady Ridgeway Hospital for Children and Castle Street Hospital for Women from 1979 to 1980. She served the Ministry of Health as RHO, Castle Street Hospital for Women, and MO at Base Hospital, Chilao. Then she joined St. Anne's Nursing Home at Maravilla, where she served as the Chief Medical Officer. Her career as a GP began in 1983, when she started her own practice. She was the proprietor and sole medical practitioner catering to all medical, pediatric, minor surgical, obstetric and gynecological patients. It also had facilities for dental surgical procedures. She also became the company medical officer of Nestle Lanka PLC in the same year, and her dual role as GP and MO in occupational health continued until 1995. She became the company medical consultant of Nestle Lanka in 1995, and she holds this post to date. Her workload included pre-recruitment medical examination of all new employees, annual medical examination of all categories of staff, maintaining medical records, advising the management on maintenance of factory medical first aid center equipment, drugs, cleanliness, performance of surgical procedures, injections, and immunization, detection and elimination of hazards at workplace, detection and elimination of hazards on the employees, standards of health and hygiene of individuals and employees at the factory, health needs of all categories of staff, food handlers in canteen, laundry, engineering, manufacturing, administration, laboratory, warehouse, security, dairy, and field staff, including domestic and janitorial services, and health education of all categories of staff. She had postgraduate training in many fields, which included child health, occupational health 1992, 2012, 2014, mental health, palliative care, and sports medicine from University of New South Wales. She was a visiting lecturer in family medicine, Faculty of Medicine, University of Colombo North, Ragama Kalaniya, October 2000, till November 2002. Dr. Carmel followed and successfully completed the course and examination leading to the membership of the College of General Practitioners of Sri Lanka in 1996. As a member of the College of General Practitioners of Sri Lanka, she contributed immensely for upliftment of family medicine in Sri Lanka. Council members, she was a council member 2000 to 2004, 2010 to 2015. She has been a trainer of trainers in counseling skills in family practice, member of the faculty of teachers of the College of General Practice of Sri Lanka, mentor and examiner MCGP examination. She has been the chairman NCD committee since 2013 and served as the vice president in 2015. She was the president of the College of General Practitioners of Sri Lanka from 2016 to 2018 and represented the college at the Royal Australian College of General Practice at GP 16 in Perth, Australia, GP 17 in Sydney, Australia, and GP 18 in Gold Coast, Brisbane, Australia. She experienced the CGPS, she represented the CGPSL in many national committees and contributed for the national development of the country. These committees included NCD Committee of the SLMA, Nirogi Lanka Project, National Advisory Committee on Comprehensive National Guidelines for Primary Care Physicians on Prevention and Early Detection of Common Breast and Gynecological Cancers. National Cancer Control Program at the National Control Advisory Committee on Guidelines in Management of NCD in Primary Care 2012. Member of the Advisory Committee on Drafting of Guidelines in Health Assessment Standards for Outbound Migrant Workers on Undiagnosed Hypertension, Cardiac Disease, and Diabetic mellitus in 2014. She was honored with the fellowship of the college in 2010. Dr. Kamal widened her experience by attending number of international conferences which included World Congress of Family Medicine in Chennai 1999, Wonka South Asia Conference in Manila in 2011, and Wonkasa 2016 February held in Sri Lanka. The Congress at the Royal Australian College of General Practice in Perth, Australia in 2016, Sydney 2017, Gold Coast, Brisbane in 2018 as an invited VIP guest and represented the College of General Practitioners of Sri Lanka during her term as president 2016 to 2018. Now I will call upon Dr. Kamal Fernandopulle to accept the Dr. B.D.J. Silva Medal for the College Orator and deliver her oration.
Thank you, Mr. President, for those kind words of introduction. Mr. President, past presidents, fellows of the College of General Practitioners, members of the Council, Chair and members of the Scientific Committee, members, associates, family members of the late Dr. B.D.J. De Silva, ladies and gentlemen. Thank you, Mr. President and the Council for selecting me to deliver the B.D.J. De Silva Oration 2022. I thank you for the honor and privilege and make this presentation as a tribute to the memory of late Dr. B.D.J. De Silva on this occasion when we commemorate his 100th birth anniversary. Dr. B.D.J. De Silva was born in 1922 and attended St. Thomas's College, Mount Lavinia. He matriculated from the University of London in 1941 and thereafter entered Ceylon Medical College, Faculty of Medicine, Colombo in 1944 and passed out with MBBS second-class honors in 1949. He started his general practice in 1952 in Maharagama and practiced for over 50 years. He has been addressed as a doctor with a simple magic cure and as an uncrowned king of Maharagama. He's been involved with the IMPA, it's been his council member and its president. He was counted among the 18 members of the IMPA who founded the College of General Practitioners of Sri Lanka in 1972. Hence, he is a founder member of the College of General Practitioners of Sri Lanka and has been its president in 1991-92. He's been on the board of management of the North Colombo Medical School, which was a gem in the crown of the College of General Practitioners of Sri Lanka as the only non-governmental institute grooming the young in the medical curriculum. And today, these young doctors are shining both locally and internationally as a great tribute to the College of General Practitioners of Sri Lanka. In 2003, he received the award of recognition of the College of General Practitioners of Sri Lanka. He was married to Doreen in 1954 and was blessed with 2 sons, Johan and Indunil, both medical specialists in Australia, and 3 daughters, Yulani, Indumani, and Karima. He was a teacher of great recognition for both undergraduate and postgraduates, an innovator, a devout Buddhist, and talented artist who specialized in charcoal frescoes. He passed away on the 9th of June 2007, coincidentally 15 years ago. I am privileged to stand on the shoulders of this great giant and consider it an honor and privilege to be selected to deliver this oration in his memory. A fitting tribute to this great man of wisdom and learning, my topic, a family physician's journey in minimizing noise-induced hearing loss, a retrospective study, an emerging challenge to the general practitioners of today in Sri Lanka, in keeping with the theme of the 47th Congress 2022. Hearing loss is the 4th leading cause of disability around the world, reported by the World Health Organization in 2015, and further acknowledged by Cunningham and Tewsey in 2017. The WHO estimated in 2018 that there are 466 million people who are disabled by hearing loss and postulated this number to increase over 900 million by 2050. The main regions of the world that are affected by hearing loss are South Asia, Asia Pacific, and Sub-Saharan Africa. This incidence is 4 times that of the high-income regions. Further, the WHO estimated in 2017 that the global expenditure as a result of hearing loss will exceed $750 billion. Hence, this epidemiological event in a country like Sri Lanka will present a major socio-economic problem. The risk factors for hearing loss are multiple, but noise-induced hearing loss remains the second most common agent, accounting for 22% in Europe. The other factors are recreational noise exposure, ear infections, and pharmacological toxicity induced hearing loss, which are all preventable, and not preventable aging and presbycusis. The pathogenesis of hearing loss is as a result of irreversible injury to the stereocilia atop the sensory hair cells in the organ of Corti of the inner ear, resulting in permanent sensory neural hearing loss. Mammalian hair cells do not grow back, unlike those in birds. In Sri Lanka, the National Institute of Occupational Safety and Health was established in April 2005, affiliated to the Ministry of Labor and Labor Relations, with a commitment to increase awareness in appropriate health and safety legislation and health and safety policy and methodologies. The establishment of national policies for good access to hearing loss investigations, workplace protection, prevention, and some available necessary rehabilitation. The Occupational Health Subcommittee of the College of General Practitioners of Sri Lanka, of which I was a member, in collaboration with the National Institute of Occupational Safety and Health of Sri Lanka, conducted a certificate course in occupational safety and health for medical officers in 2012 and 2014. The College of General Practitioners of Sri Lanka grooms family physicians to manage general or unselected health problems, provide continuous or continuity of care, comprehensive care with health promotion, coordinated care with timely referrals, collaborative care with teamwork with other disciplines, which is family-orientated and community-orientated. I started a full-time solo family practice in Dankotua in March 1983, having worked in the state sector for 4 years as a grade 2 medical officer. And in July 1983, joined Nestle as part-time company medical officer in its newly established international food and beverage factory in Pannala. A full-time qualified nurse was employed, a medical examination form was designed, together with other records and statistics for the month maintained. A detailed social history, past medical history including ear disease, occupational history in the immediate past 3 years, in keeping with medical surveillance, which targets actual health events or a change of a biological function of an exposed person. A focused examination with results of laboratory reports, relevant to food handlers, made me recommend one to be mentally and physically fit to work in the allocated role in the designated area of the factory. Nestle Lanka PLC started as a trading company in Sri Lanka over 100 years with the introduction of milk and infant foods. It has grown to be one of the leading food and beverage companies, providing direct employment to almost 1,200 people and positively impacting the livelihoods of over 23,000 distributors, suppliers, farmers, and their families. The state-of-the-art manufacturing facility Nestle Lanka factory in Kurunegala now manufactures 90% of their products using heavy machinery in the milk, powder processing, beverage, and nucifera sections. In 1983, Nestle Lanka factory was a simple milk factory and has grown down the years with constructional changes, adding numerous products to its portfolio. Noise levels recorded in the 2008 survey indicated 87 to 90 decibels in the evaporated milk processing, 90 decibels to 100 decibels in the milk processing, and 85 to 90 decibels in the beverage section, 85 to 99 in the area engineering. The noodle and vending mix section ranged between 81 to 82 decibels. The OSHA recommendations recommend a standard permissible level of 85 decibels exposure for 8 hours per day. Increase of sound by 3 decibels increases the sound energy by 2-fold, needing the exposure time to be halved. Nestle mapped out a plan to use engineering controls to reduce the workplace ambient noise levels with administrative controls and preventive measures, like soundproof cubicles which isolate the worker, passive protection of workers using hearing protection devices like earmuffs and earplugs. The quality, the attenuation levels of noise are legal requirement known as noise reduction rating, which is usually 10 to 15 decibels. At Nestle, we use a ear guard, which has an NRR of 30 decibels, and an NRR for the earplugs is 25 decibels. Proper usage of these protective devices is monitored, and employees are advised on the need to conserve hearing. Warning posters with signage highlights noisy areas and processes with restricted entry to authorized personnel wearing PPE. Employee monitoring. Individual susceptibilities vary, and those predisposed to genetically mediated progressive diseases, medical conditions, and use of medications were noted on pre-recruitment and at annual medical examinations. The safe level of 80 decibels for 40 hours per week, a Nestle requirement, is strictly regulated, with all employees working in these areas not allowed to exceed the stipulated noise exposure periods, rotated in their workstation, routinely examined and counseled. In 1993, an employee submitted an audiogram reported by an otorhinolaryngologist stating occupationally induced hearing loss. A detailed occupational and past medical history revealed repeated urinary tract infections treated with ototoxic drugs. This prompted me to carry out a retrospective study on work-related hearing loss on a cohort of employees in the background of Nestle facilities. The index period is from 2016 to 2020. The numbers were identified. Necessary information was collected from the paper-based documents retrospectively and analyzed. Audiograms were done pre-recruitment and repeated in 6 months while in the workstation to identify temporary threshold shifts, repeated 1 year later. Annually, in those working in noisy areas and those showing deteriorations in hearing threshold. The laboratory at the National Council for the Deaf, situated at Rajagiriya, which is adequately monitored and equipment periodically calibrated, is used since 1993. Now we have the laboratory at Navaloka Hospital, Negombo, with a qualified audiologist, color-coded graphical representations. And this also helps them not to travel to Colombo to get the audiograms done, and this we've been using from 2016. The regional Nestle requirements updated in 2016 mandated audiograms be repeated every 3 years. Any deterioration in hearing is noted and the etiology looked into. Conductive losses at pre-recruitment were subjected to remedial corrective procedures and even surgery in keeping with the hygienic requirements. And those sensitized to noise were followed up closely, posted into less noisy areas and followed up with audiological recordings and referred to the same consultant. The principal characteristics of noise-induced hearing loss are: occupational noise-inducing hearing loss is always a sensorineural loss affecting hair cells in the organ of Corti. It's typically bilateral and generally symmetrical. As hearing loss progresses, the rate of hearing loss decreases. Loss is always greater at the frequencies of 3,000 to 6,000 Hz, then at 500 to 2,000 Hz. And loss is greatest at the 4,000 Hz, as depicted in this slide. The 4,000 Hz notch in occupational noise-induced hearing loss, although not pathognomic, is a characteristic audiometric pattern in early noise-induced hearing loss, which is often preserved even in advanced stages. That is, a dip at 4K and recovery at 8K. However, with advancing age, this recovery is not so. In stable exposure conditions, losses at 3,000, 4,000, and 6,000 usually reach a maximum level in 10 to 15 years, unlike presbycusis. Hearing loss does not progress once noise exposure is discontinued. In 1990, Robert Dobie, the clinical professor of otolaryngology of the University of Texas, added criteria for the diagnosis of occupational noise-induced hearing loss. Clinically, noise-induced hearing loss begins as a temporary threshold shift that recovers almost completely once the noxious stimulus is removed. Sometimes recovery is attained 16 to 48 hours later, but may require days or months, especially if the case is associated with acoustic trauma. As a practice, 24 hours is commonly used. Recent research suggests, however, that although the loss of hearing seems to disappear, there may be residual long-term damage. Repeated temporary threshold shifts over weeks, months, and several years fails to recover completely and becomes a permanent threshold shift. All records are paper-based, and hence mining has been tedious and time-consuming. The age of workers ranges from 21 to 55, with a mean of 34.95 years. All employees have been coded to maintain confidentiality, with emphasis on designation and section or department employed in. Hence, a retrospective study was carried out to assess the work-related sensory neural deafness in one independent center to assess the incidence, evidence of prevention, and establish possible solutions. Data was collected from serial audiograms from 2016 to 2020 in all employees in the factory. And the hearing levels in decibels in the left and right ears in the 4 kHz range was entered into a Microsoft Excel sheet and analyzed using SPSS analytical methods. Graphical representations as shown. The left ear is in blue and the right is in red. Total counts were plotted in the ranges against hearing. Normal less than 25 decibels, mild more than 25 decibels, moderate over 35, and severe more than 55. In 2016, normal hearing was seen in 302 patients, and in the left ear and 309 in the right, with mild hearing loss 37 in the left and 38 in the right, and moderate to severe loss of 18 in the left, 10 in the right, and severe 1 in the left and 1 in the right. The sample size was 358. Records of 2020 in those working in noisy areas showed that the normal hearing was the sample size was 399 because we included those recruited from 2017, 18, 19, and 22. Normal hearing was seen in 355 in the left and 354 in the right. Mild loss of 24 in the left and 31 in the right. Moderate loss of 17 in the left, 13 in the right. And severe loss of 3 in the left and 1 on the right. The prevalence of normal hearing in 2016 was 84.35 in the left ear and 86.3 in the right ear. A moderate loss of 5.02% in the left and 2.7% in the right. In 2020, the normal hearing was 88.75 in the left and 88.5% in the right. A moderate loss was seen in 4.25 in the left and 3.25 in the right. Severe loss of 0.75 in the left and severe loss of 0.25 in the right was detected. The reason for this is in 2015, 2 skilled workers with hearing levels exceeding 60 decibels in the left ear were recruited. Hence the reason for L3 in 2020 in the severe category. R1 is an employee who showed severe loss due to ear infection in childhood, recruited in 2013. The findings showed a very mild prevalence of moderate sensorineural loss in the right ear and a very mild prevalence of severe sensorineural loss in the left ear, showing a minimum hearing deterioration over the study period of 4 years. You got to excuse me because the normal is not in one extreme, the mild is not following it, and the moderate, because the statisticians said that this is what is possible in a statistical analysis. So that's why you see mild on this side on the left, moderate there, normal around, and then severe at the other end. So it's not by design. The exclusions and inclusions were exclusions. We have 20 females in the factory. 7 of these work in the noodle and bullion section where the noise is less than 81 decibels. And the rest 13 work in administration and laboratory in quality assurance. Hence, gender distribution was not analyzed. And the age group that is at Nestlé's is up to 55 years. And so those over 60 were not analyzed. Inclusion criteria was those working in the beverage, where noise ranges from 85 to 95. Milk powder processing 90 to 100, area engineering over 100, and the rest of the factory where noise range from 76 to 81 included in the study. And those showing bilateral loss in hearing levels significant of occupational noise-induced hearing loss, and those showing unilateral hearing defects, 2 were included in this study. A further analysis of those working in the noisy areas for a period less than 1 year in 2016, and those working for more than 1 year from 2013 were tabulated and tests repeated in 2020 in the frequencies of 2K, 4K, and 8K. The numbers depicted are as shown. The hearing level changes were not very significant, and here we added the left and the right ears. So you see the 2K is in blue, the 4K is in green, and the yellow bands are the 8K. It's the 4K that is significant, although we have seen some changes in 2K and 8K. And in 2016, there was 1 mild case in the 4K region, and 26 of them were normal, and 5 in the severe. In 2020, there is 1 mild case, 1 case in the moderate region, and 5 remaining in the severe. The numbers in the mild in 2020 have increased in 2K and 4K. This is because of the COVID situation and the long shifts at Nestlé's, sometimes 12 hours. But these findings, this is not a representative sample, so these findings were not very significant. Hearing depends on a series of events that change sound waves in the air into electrical signals. The auditory nerve carries these signals to the brain through a complex series of steps. Noise is a major health and safety issue in factories with heavy machinery. Sounds of less than 75 decibels, even after long exposure, are unlikely to cause hearing loss. The factors affecting noise-induced hearing loss: the type of exposure, the distance from the source of the sound and the length of time one is exposed. Steady-state sound is harmful when too loud and even for a brief time, or when they are both loud and long-lasting, such as noise generated in a woodworking shop. Impulse or impact exposure is a one-time exposure, causes acoustic shock injury, and this impact is very severe. Recreational activities that put one at risk for noise-induced hearing loss: target shooting, hunting, snowmobile riding, water sports. Music and personal listening devices like MP3 players with earphones present risks to hearing if used at too high a volume for too long. Playing in an orchestra or band or attending loud concerts is injurious too. Environmental and non-recreational noise is harmful. Noises at home may come from sources including lawnmowers, leaf blowers, woodworking tools, construction equipment, and machinery. The clinical effects and signs of noise-induced hearing loss: Noise-induced hearing loss is irreversible, hence early detection and intervention is critical in preventing and improving hearing. Noise-induced hearing loss can be immediate or can take a long time to be noticeable. It may be temporary or permanent, affecting one or both ears. The symptoms of noise-induced hearing loss are non-specific and do not help to distinguish among etiologies. That's ototoxicity, genetically mediated progressive losses, or presbycusis. The damage from noise-induced hearing loss combined with aging can lead to hearing loss severe enough to interfere with hearing, communication, and activities of daily living. Loud noise exposures can also cause tinnitus, which may subside over time, continue constantly, or occasionally. Hearing loss and tinnitus can occur in one or both ears. The indirect effects of noise are the negative effects on work or domestic relationships, leading to depression and social isolation. Safety issues interfering with warning signals and increased risk of accidents. Hearing generally declines with age, and the average healthy, non-noise exposed person can have essentially normal hearing up to age 60. Individual susceptibilities vary in those with medical conditions and those warranting the use of ototoxic drugs, some antibiotics, salicylates, aminoglycosides, diuretics, to name a few. Comorbidities like diabetes mellitus, high blood pressure, and hypercholesterolemia are very injurious for hearing. Smoking too contributes or aggravates noise-induced hearing loss. Preventing occupationally induced hearing loss is a complex job. It involves an audit on the existing system, administrative issues, and following the Occupational Safety and Health Association regulations. A hearing conservation program strives to prevent initial occupational hearing loss, preserve and protect remaining hearing, equip workers with knowledge and hearing protection devices. A hearing conservation program audit should be considered annually, identifying the critical measurements that need to be taken and how often they should be repeated, and developing a system with appropriate measures. Preventing occupational hearing loss is to remove or control the hazards by good engineering and administrative controls. Personal hearing protection devices, the earplugs or the earmuffs, properly selected and used, are powerful tools for preventing noise-induced hearing loss. Monitoring audiometry and related record keeping, which help identify deteriorations, are critical parts of the hearing conservation program. And it involves checking the training and experience of the audiometric testing program, the quality of the audiograms, the training and certification of the audiometric technicians, continued recertifications, adequacy of the testing environment, the methods used, regular calibration of instruments, and communication of test results to the employees, and follow-up procedures for employees showing shifts in hearing thresholds. Regular testing of employees' hearing is the most effective means of ascertaining that hearing loss is being prevented. Those whose hearing does change for the worse need referral to a consultant otorhinolaryngologist with timely and accurate transmission of records and guidelines for providing evaluation and treatment of hearing loss or ear disease determined to be not related to the hazards at the workplace. Working in a safe and healthy environment can stimulate innovation and creativity and result in increased performance and higher productivity. In this retrospective study conducted over 4 years, hearing is conserved. There was no significant deterioration detected. The strict regulatory, engineering, and stringent administrative controls over work schedules with intermittent breaks, aided by medical surveillance with serial monitoring, audiometry, timely referrals to the specialist care, and record keeping has helped towards this end. The shortcomings identified and limitations are, during the COVID situation, all employees could not be exempt from work to undergo testing, and so there were no controls to be compared. In addition, there was a limitation on the numbers being tested per day. The 14-hour mandatory noise-free period prior to measurement could not be adhered due to constraints on work schedules. The numbers showing a mild loss being higher in 2020 could be due to the temporary threshold shifts following the 12-hour work shifts, as I indicated earlier on. Deteriorations 5 years since recruitment and 10 years could not be analyzed in all employees, as there were no corresponding values in the controls from 2008 to 2015, and the recent metabolic levels in the 15 diabetics, the 13 hypertensive, the 142 with hypercholesterolemia, and the 6 having ischemic heart disease were not available to aid comparison. NIOSH recommends that only 5% of workers show 15 decibel significant threshold shifts. Same year, same frequency. Our results are within this requirement. In 2016, it was 5.02% in the left ear and 2.7% in the right. In 2020, it was 4.25 in the left ear and 3.25 in the right ear. We comply with NIOSH recommendations of immediate notification in writing to employees showing a significant threshold shift, and employees should be encouraged to use PPE at home while engaging in noisy, non-occupational activities in an attempt to reduce recreation and environmental noise. The cardinal principle of family medicine is continuity of care, together with comprehensive, coordinated, collaborative, holistic care in the community. This has helped me take utmost care of all the employees and the employer. Special thanks to Dr. W. Ratnayaka, the consultant otorhinolaryngologist of the National Hospital of Sri Lanka, for his continued support in evaluating all these employees from the inception. Dr. Amal Fernando, who is here in the audience today, thank you very much, sir, for coming in. Consultant otolaryngologist from the District General Hospital, Gampa, for evaluating the employees, his expertise and guidance in this presentation. Professor Janaka Ramanayaka, the Professor of Family Medicine, the University of Kelaniya, for the continued support, the guidance, and the advice in making this presentation a reality. Ms. Pavitra Basnayaka of the Statistics Department, University of Kelaniya, for her commitment and detailed statistical analysis. Timothu Veerasekara, Udara Fernando, Shamila Disanayaka for the typesetting, and Professor Ilan Kovan and Dr. Hira Javed of UK for the preparation of the slides. Many other persons at Sri Lanka PLC who contributed to this presentation. The management staff of the head office and factory, and its employees. Nestle for creating the permissive and the collaborative environment that supported this work. I thank Almighty God, my parents and family for the work ethic, values, humility, discipline, and guidance. My school, Gujarat Convent, Colombo 13, for the quality education. The Faculty of Medicine, University of Colombo, lecturers, consultant, peers for their contribution. I'm truly indebted for life, and I thank all my batchmates who are over here today. I'm very thankful that you have been able to make it in these very trying days to be, and very precious to some who have even postponed their surgical operation list. Thank you very much for being here today. My husband, Colin, the wind beneath my wings, and my children, Krishen with Harini and Krishel, and Krishani with Nuina and Tevi, for supporting me with wonderful memories. These are my references. I leave you with these words from Albert Einstein. The world is not dangerous because of those who do harm, but because of those who look at it without doing anything. Thank you.
Thank you very much, Madam, for that very interesting and thought-provoking oration. I now cordially invite Dr. Dilini Baranage, the chairperson of the Mentoring Committee, to speak a few words about celebrating a decade of mentoring excellence as the college celebrates 10 years of mentoring.
President, council members, the orator, Dr. Kamal Fernandopulle, distinguished guests, ladies and gentlemen. Celebrating a decade of mentoring excellence. It is indeed an honor to address you all at this moment as the mentoring program of the College of General Practitioners completes 10 years since its inception in 2012. The first mentoring workshop was held in April 2012 at the Lady Ridgeway Hospital Auditorium, and due to the overwhelming enthusiasm, the second workshop was also held in the same year in September. At this point, I would like to extend our sincere gratitude to all the seniors who were there at the initiation of this program, and some of them are still with us in the mentoring committee, guiding the mentor pool even now. So let's look at the structure of the mentoring program of the college. So it's categorized into 3 stages: GP mentoring, MCGP mentoring, and membership mentoring. GP mentoring is where we allocate a mentor to a doctor who wishes to set up a general practice. MCGP mentoring, the most active mentoring program out of these 3. That MCGP mentor is allocated to an MCGP trainee who enrolls to the MCGP program. The MCGP mentor guides the trainee throughout the 2-year course. And mentor-mentee allocation usually is done according to the special interest, and also a mentor who is not working in the same area but not living far away is allocated to the MCGP trainees. Membership mentoring. Membership mentor is allocated to a MCGP diploma holder who wishes to apply for college membership. The college mentor pool consists of almost 60 mentors, and there are annual mentoring workshops as a training program for all these mentors. And let's look at the criteria to enter the mentor pool. A doctor should have the MCGP diploma and should attend 2 mentoring workshops. Then you're eligible to enter the mentor pool, and once they work as a mentor, their work is recognized and they are awarded a plaque. And their work is again appreciated at the inauguration of the mentoring MCGP batch and awarded a certificate as well. And the analysis of all these mentors is done by feedback obtained from the mentees as well as from the mentors. A handbook on mentoring was developed by the mentoring committee some years back, which gives a detailed description of the mentoring program of the college. And let's look at the functions of the mentoring committee. Recruiting and matching mentors and mentees, offering post-match support, resolving issues, ensuring the volunteer basis of a mentor, and evaluation of mentors, and recognition and appreciation of mentors. And I'm proud to say that this year the MPM Curre College Oration also was based on mentoring. And last year, the University of Colombo launched the academic mentoring program for all the professional colleges. And I'm proud to say the College of General Practitioners were invited as resource persons for this launch. So finally, let's look at the positives and the negatives of a mentoring program. Let's look at the positives first. It guides and facilitates the trainee, helps in personal and professional development, provides information, identifies problems, identifies resources during the MCGP program. Let's look at the negatives. Mentees are unaware of the value and concept of a mentoring program, which sometimes leads to a failed mentor-mentee interaction, and there are instances when the mentee does not want to be mentored. So once again, I would like to extend my gratitude to all the seniors who initiated the mentoring program, and we have now completed a decade this year. Thank you.
Thank you, Dr. Barnage. May I kindly request all of you to please rise as the academic procession will now leave the hall.